Okay, so now let us start with 52nd chapter of your Apurba S Sastry Essentials of Microbiology, which is beta hemolytic streptococcal infections. In this chapter, we will be previewing the Streptococcus pyogenes infections and the other beta hemolytic streptococcal infections. In this video, we will be covering Streptococcus pyogenes infections, pathogenesis and epidemiology, while the lab diagnosis and the further chapter will be covered in the subsequent videos. Introduction. Family Streptococcaceae are catalase negative gram-positive cocci arranged in pair or chains due to single plane of division. Streptococcus, Enterococcus, and Pneumococcus are the important molecular structure. Enterococcus is now reclassified under separate family Enterococcaceae. Streptococci are part of normal flora, however, some are important human pathogens, such as Streptococcus pyogenes causing pyogenic infections, Streptococcus agalacti causing meningitis in newborn, and Streptococcus pneumoniae causing pneumonia and meningitis in all age groups. History. Belleroth coined the term streptococci, streptos meaning twisted or coiled. Oxton differentiated them from staphylococci, and Rosenbach coined the species Streptococcus pyogenes as it causes pyogenic infection. Classification. Streptococci can be classified into obligate anaerobes, example Peptostreptococcus described in chapter, and aerobes and facultative anaerobes group. The latter can be further classified based on the hemolysis produced on 5% sheep blood agar into alpha, beta, and gamma hemolytic streptococci. Alpha hemolysis. It is due to partial lysis of red blood cells RBCs producing a small 1 to 2 mm zone of greenish discoloration surrounding the colonies. It is observed with viridins, streptococci, and pneumococci. Beta hemolysis. It is due to complete lysis of RBCs and zone of lysis is wide 2 to 4 mm. It is observed with Streptococcus pyogenes and other beta hemolytic streptococci. Gamma hemolysis is a misnomer. There is no hemolysis surrounding the colonies, hence no change in color. Example Enterococcus. Lancefield grouping. The beta hemolytic streptococci were further reclassified by Rebecca Lancefield based on C carbohydrate antigen present in the cell wall and up into 20 serological groups named group A to V except I and J. Griffith typing. Majority streptococci causing human infections belong to group A, Streptococcus pyogenes, which can be further classified into more than 150 serotypes based on M protein present in the cell wall. Genotyping based on EMM gene encoding M protein, group A streptococci can be typed into more than 200 genotypes. Now, in this figure, we can see the streptococci based on oxygen requirement. They can be classified into aerobes and facultative anaerobes or the obligate anaerobes like peptostreptococci. Now, the aerobe and facultative anaerobes based on hemolysis can be classified into alpha hemolysis, viridins, streptococci, and pneumococcus. The beta hemolysis, beta hemolytic streptococci, and the gamma hemolysis, which is enterococcus. The beta hemolytic streptococci based on Lancefield grouping can on the group specific C carbohydrate antigen is classified further into 20 serogroups A to V except I and J. The group A consists Streptococcus pyogenes, Griffith typing based on M protein and genotyping based on EMM gene. It is classified to more than 150 M serotypes and more than 200 EMM genotypes. Now, coming on to Streptococcus pyogenes infection. A Streptococcus pyogenes is the only species under Lancefield group of Group A Streptococcus gas. It is associated with a variety of suppurative infections and can also trigger post-infectious non-suppurative complications such as acute rheumatic fever and acute glomerulonephritis. Virulence factor and pathogenicity. Virulence factor of Streptococcus pyogenes can be categorized into the cell wall antigens, toxins, and enzymes. Cell wall antigens. The cell wall of streptococci is primarily composed of peptidoglycan layers in which a variety of substances are embedded such as carbohydrate, teichoic acid, lipoprotein and surface protein antigens. Lipoteichoic acid helps in the adhesion to pharyngeal epithelial cells and to other host cells and proteins such as fibronectin. C carbohydrate antigen. They are group specific antigens form the basis of Lancefield grouping. M protein is the principal virulence factor of group A streptococcus. Other cell wall proteins such as Fimbriae and F factor, fibronectin binding protein, help in adhesion. The M protein associated protein opacity factor associated with skin infections. Capsule. Some strains of group A streptococcus are capsulated made up of hyaluronic acid. These strains produce mucoid colonies. Capsule is antiphagocytic but not antigenic. It helps group A streptococci to colonize the pharynx by binding to CD44, a hyaluronic acid binding protein expressed on epithelial cells. M protein. It is the principal virulence factor of group A streptococcus. It inhibits complement mediated opsonization by phagocytes. Antibody to M protein is protective in nature and promotes phagocytosis. It complexes with fibrinogen that consequently bind to beta 2 integrins of neutrophils, leading to release of inflammatory mediators which induce vascular leakage, causing streptococcal toxic shock syndrome. Some M protein types are cross reactive to human myocardial antigens and play an important role in the pathogenesis of rheumatic fever. The toxins. Hemolysin. Beta hemolytic streptococci such as group A, C, and G produce two hemolysins, streptolysin O and streptolysin S. They cause RBC membrane lysis that lead to complete beta hemolysis surrounding the colonies. They can damage the membrane of neutrophils and platelets. In this table, we can see the difference between streptolysin O and S. Streptolysin SLO, oxygen labile, hence named as streptolysin O, which is heat labile, while streptolysin S is oxygen stable, serum soluble, hence named streptolysin S. SLO is strongly antigenic while SLS is non-antigenic. SLO is anti-streptolysin O antibodies are raised in most of the streptococcal infections and are used as standard marker for retrospective diagnosis of streptococcal infection, except in glomerulonephritis and pyoderma where ASO titer is low. In SLS, it is not useful for the serological diagnosis of streptococcal infection. Now coming on to streptococcal pyrogenic exotoxin SPE. It is so named because it induces fever, pyrogenetic. It has been responsible for pathogenesis of certain streptococcal infections such as scarlet fever, necrotizing fasciitis, and toxic shock syndrome. It can be typed into three well-described antigenic distinct subtypes SPEA, B, and C. SPEA and C are bacteriophage coded, whereas SPEB is chromosomally mediated. SPEA and C are superantigens like staphylococcal toxin TSST1. They also act as T cell mitogens which induce a massive release of cytokines causing fever, shock, and tissue damage. Enzymes. Streptokinase fibrinolysin. It activates plasminogen to plasmin, thus breaks down the fibrin barrier around the infected site, thereby facilitating the spread of infection. Antibodies to streptokinase can be used for retrospective diagnosis of streptococcal infection. Therapeutic use being fibrinolytic toxin can be used in the treatment of myocardial infarction and other thromboembolic disorders. Streptodor DNase. It breaks down the DNA, thus helps in liquefying the thick pus containing large amount of DNA derived from nuclei of necrotic cells and may be responsible for the serous nature of the streptococcal exudates. Therapeutic use. Preparation containing streptodornase and streptokinase can be used to liquefy the thick exudates in empyema cases. Subtypes. Streptodornase has four distinct subtypes DNase A, B, C, and D, of which type B is the most antigenic. Diagnostic use. Anti-DNase B antibodies can be used for retrospective diagnosis of infection, particularly the skin infection, pyoderma, and acute glomerulonephritis where ASO titer is low. Other enzymes. Hyaluronidase spreading factor. It breaks down the hyaluronic acid present in the tissues, thus helps in the spread of infection along the intercellular space. Others include NADase, nicotinamide adenine dinucleotidase, serine protease, C5a peptidase, neuroaminidase, N-acetylglucosaminidase, esterase, and phosphatase. Clinical manifestation. Group A streptococcus gas produce both suppurative and non-suppurative infections. Throat is the primary site of infection by gas. Infection occurs through respiratory droplets. Suppurative infection, respiratory infection, Streptococcus pyogenes is the most common bacterial cause of pharyngitis, sore throat in children, and accounts for 5 to 15% of all sore throats in adults. Infection occurs through respiratory droplets. It can really cause other respiratory infections such as scarlet fever, pharyngitis and rashes, pneumonia or empyema. Superficial skin and soft tissue infections, impetigo pyoderma. It is a superficial infection of skin caused primarily by group A Streptococcus and occasionally by other species of Streptococci or Staph aureus. Risk factors include young children, warmer months, tropical climates, poor hygiene, colonization by group A Streptococcus, and minor trauma. Most common sites involved are face, nose and mouth, and legs. Suppurative and non-suppurative manifestation of Streptococcus pyogenes. Suppurative: respiratory infections, pharyngitis, sore throat, scarlet fever. Other which are rare are pneumonia, empyema, quinsy, sinusitis, and otitis media. The non-suppurative ones include acute rheumatic fever and acute glomerulonephritis. The skin infections in suppurative include the impetigo pyoderma and cellulitis and erysipelas, while in the non-suppurative they include guttate psoriasis, reactive arthritis. And the deep soft tissue infection in the suppurative include necrotizing fasciitis, streptococcal myositis, bacteremia leading to endocarditis, osteomyelitis, septic arthritis, meningitis, etc., toxic shock syndrome, and pleural sepsis, which is rare. While in the non-suppurative, it includes pandas, pediatric, autoimmune, neuropsychiatric disorders associated with streptococcal infections. Okay, now see in this image we can see the streptococcal skin infection. In A image it shows impetigo, while in B it shows erysipelas on malar area of the face, which is responsible for pudgy orange skin. Individual lesions begin as red papules which evolve quickly into vesicles and then pustular lesions that break down and coalesce to form characteristic thin papery honeycomb-like crust. Lesions are painless and not associated with fever. Cellulitis, it involves the skin and subcutaneous tissues. Erysipelas is the form of cellulitis characterized by a tender, bright red, swollen, and indurated pudgy orange texture of the involved skin due to the involvement of superficial lymphatics along with fever and chills. Superficial blebs or bullae may form later. Most common sites are malar area of face and the lower extremities. Recurrences are common, often after many years, involving the same site. Next is deep soft tissue infection, necrotizing fasciitis. It is also known as hemolytic streptococcal gangrene. It involves the superficial and or deep fascia invading the muscles. Source: the source of the infection may be two types. A traumatized skin, most commonly caused by group A Streptococcus alone or with Staph aureus. Gastrointestinal tract breach, it occurs due to abdominal surgery releasing the bowel flora. It is polymicrobial involving anaerobic flora and gram-negative bacilla like E. coli. Gas is the most common cause, accounting for nearly 60% of total cases of necrotizing fasciitis. Common serotypes include M types 1 and 3, which produce streptococcal pyrogenic exotoxins. The onset is acute and rapid and is marked by severe pain with minimal erythema and the site of involvement. Patients present with malaise, fever, chills, and a toxic appearance, in contrast to cellulitis when the skin appears more abnormal but tenderness is mild. In this image, we can see the necrotizing fasciitis of leg. Later on, over several hours, disease tends to be more severe. Skin becomes dusky or develops mottled erythema and anesthetized due to the infarction of cutaneous nerves induced by spreading inflammatory process. With extensive necrosis of subcutaneous tissue, fascia, and muscle, hence gas is also called as flesh-eating bacteria. Bacteremia, streptococcal bacteremia occurs secondary to necrotizing fasciitis, rarely with pharyngitis or cellulitis or pneumonia. It leads to a variety of focal infections including endocarditis, meningitis, septic arthritis, osteomyelitis, peritonitis, visceral abscess, and toxic shock syndrome. TSS or the toxic shock syndrome, group A streptococcus producing pyrogenic exotoxins may cause TSS secondary to soft tissue infections such as necrotizing fasciitis. In contrast to patients with staphylococcal TSS, the majority with streptococcal TSS are bacteremic. In case, definition of TSS include isolation of streptococcus pyogenes plus hypertension plus multi-organ more than equal to two organ involvement. Plural sepsis. Being colonizer of female vagina, streptococci are often associated with infectious complications of childbirth, usually endometritis and associated bacteremia. Group B streptococci and anaerobic streptococci are more common to cause puerperal sepsis than gas. Non-suppurative complications. Streptococcal antigens show molecular mimicry with human antigens due to the antigenic cross-reactivity antibodies produced against previous streptococcal infections cross-react with the human tissue to produce lesions. This accounts for a number of non-suppurative complications such as acute rheumatic fever, post-streptococcal glomerulonephritis (PSGN), guttate psoriasis, reactive arthritis, pediatric autoimmune neuropsychiatric disorders associated with streptococcus pyogenes called as PANDAS. Antigenic cross-reactivity between streptococcal antigen and the corresponding human antigen. Streptococcal antigen cell wall M protein of serotypes M1, M5, M6, M19 corresponds to human antigen of myocardium, tropomyosin and myosin. Cell wall C carbohydrate of streptococcal antigen corresponds to cardiac valves antigen of human. Streptococcal antigen with cytoplasmic membrane corresponds to glomerular vascular intima of human antigen. Peptidoglycan of streptococcal antigen correspond to skin antigen of human. Hyaluronic acid of streptococcal antigen corresponds to synovial fluid of human antigen. Acute rheumatic fever or ARF occurs in people previously infected with streptococcal group A sore throat as a result of an autoimmune reaction. It is a multisystem disease causing cardiac valvular damage, rheumatologic and neurologic manifestation. Patients have elevated streptococcal and streptolysin O antibodies. Post-streptococcal glomerulonephritis (PSGN). It typically occurs in children following streptococcal pyoderma or rarely pharyngitis, characterized by lodging of antigen-antibody complex on the glomerular basement membrane followed by complement activation. Patients have elevated streptococcal anti-DNase B antibodies. It is discussed later. Epidemiology. Humans are the natural reservoir of group A streptococcus. It is highly communicable, affecting all age groups. Disease in neonates is uncommon due to protective maternal antibody. Pharyngitis is more common in children of 3 to 15 years of age. Outbreaks occur commonly in areas with close contacts, such as school and military barracks, etc. So, this completes part 1 of the chapter. The next part will be covering lab diagnosis and the other infections. Okay, like, share, subscribe. Thanks for watching.